Thank you, Riz, for having me here today to talk about your role as practice manager in a general practice. And to begin with, could you tell me about what your role involves and the type of work that you undertake?
Yeah, sure. So we are a GP practice, a partnership, so a private business delivering an NHS contract to patients. So we have 11,000 patients that are registered with us in the locale that come to us as a first point of call for any issues relating to their health and general well-being. There's a lot of issues regarding general access and making sure that patients can get seen as quickly as possible, and we're constantly monitoring things to ensure that we give patients the best possible time and appointment facilities to come and be seen within what is deemed acceptable. We've got 25 members of staff, most of them part-time. We have 8 GPs, 3 nurses, 2 healthcare professionals, and a team of admin staff here to support the clinical side of the business to ensure that everything runs as smoothly as possible. My role is to basically ensure the day-to-day running of the business goes as seamlessly as possible. I try to ensure that there are any issues that do arise are dealt with as quickly as possible, and the continuation of the service runs as smooth as we can.
So you've referred to it as a business. Could you tell us a bit more about the contractor model? So how is it that general practices function as independent business units?
So NHS England, they put out GP contracts for us to sign up to or not sign up to if you prefer to remain a private GP practice. Most GPs do at least the majority of the NHS contract, if not all of it. And within that contract, there are some standard things that you have to deliver, as well as some optional extras. So to gain extra bits of funding, for example, there are enhanced services that you as a practice would decide whether or not you would go for. So that would be a decision made by the GP partners and myself as to what's best for the practice and for our patients. So us, for example, we try and deliver as many as possible because a lot of the enhanced services that NHS England try to get us to sign up for are in the general interest of the patient.
And can you give me examples of some of those enhanced services?
Yeah, sure. So one of the biggest ones at the moment is extended hours. So we're trying to get more and more GPs providing extra hours of business, so staying open longer and adjusting how they work as well. Traditionally, for example, a lot of GP practices would close for about an hour or so for lunch, or sometimes they would close between the morning and the afternoon sessions for patients. And what we do, and we have done for quite a while, is actually stay open throughout the day. So as well as that, the contract asks for hours to be created to see patients both before 8 AM and after 6:30 PM. So people who work, for example, can see their doctor or their nurse either before 8 o'clock in the morning or after 6:30 in the evening, which might be more convenient for them. So we provide that 4 days of the week. And because we provide a minimum amount of hours per 1,000 patients, we get a certain amount given to us by NHS England.
And in terms of your role and putting all of that into place, did you face any challenges around extended opening times?
The obvious one is staff, and ensuring that we have enough clinical staff to facilitate that, supported by admin. So we will often have at least one person at the reception desk beyond 6:30 in the evening till 8 o'clock at night to ensure that they're there to greet patients and ensure that the front end of the service is provided sufficiently and runs as smoothly as possible before they're called in to be seen by the doctor. that causes a bit more of a problem with the morning session. So we have a session from 7:30 till 8 in the morning, where the nurse actually, she comes in and sees the patients at the front end as well as treats them when in her clinical room. So we've had a few challenges around that, but we've generally found a way to get round it, either by having at least one person on board, or if the nurse is willing to just facilitate it herself.
So I'm already getting a sense of your role having quite a lot of layers to it. So you seem to take action at different layers of the organisation. There's the bits that you would do around your immediate team, but also thinking about how the practice provides an interface with your patient population. So if you were going to describe your typical day to me, if there is such a thing, could you do so and also highlight where you would be interacting with different layers of the organisation?
One of the reasons why I really enjoy my job is because there are so many different facets to it, and to say that a typical day, well, there is none really. Generally speaking, you have the top layer of things that you've got to deal with. So you're talking about the strategy of the business, and doing the finances on a almost day-to-day basis to ensure that invoices are being paid and we're getting money for the services that we provide from NHS England and the CCG and anywhere else. Then there is the staff aspect of it, ensuring that the HR aspects of the business run smoothly, training as well, that's all done. And then, of course, there's the customer-facing or the patient-facing side of the business, which is ensuring that their experience is what they would expect it to be, and that any issues that they have are dealt with as swiftly as possible and to their satisfaction. Then there's just general facility work. We have a building here that is not a bespoke designed medical centre, it's a converted large semi-detached house that's been extended 2 times over the past 20 odd years. And so with that comes the gratuitous wear and tear, and because it's an old building from the 1930s, issues that arise from that. So just keeping everything functioning from that perspective is also an element of your job. So there are really quite a few different areas that you'll be working in, and when you walk in the door of a morning, you're never 100% sure exactly what you're going to be called in to deal with.
And would you say that you find that quite motivating?
Yes, I mean, I think I would personally get quite bored coming in, sitting at my desk doing the same job every single day. One of the things that I like about the role is the fact that there is such a diversity to it, and the fact that you can be involved in various aspects, which gives you a certain amount of personal satisfaction.
And within your typical day, we've learnt there isn't such a thing, but do you refer to any professional standards or regulation? And if you don't directly yourself, do the general practitioners within the practice work to particular standards or codes of conduct?
Yes, so we have all the clinical staff work to their own governing bodies standards, so ensuring that they are conforming to all relevant clinical regulations. As a practice, we have to try and adhere as best we can to CQC regulations, that's the Care Quality Commission, as well as NHS standards as well, so things about data security, infection control, safeguarding, confidentiality, equality and diversity. All these different aspects of what is an acceptable NHS standard have to be applied here as well.
Great, that's a good overview. Thinking about the context of public health and thinking about London and some of the demands that are placed on a general practice, can you tell me anything about that context and how it may affect you working as a practice manager day to day?
Yeah, I mean, the key problem, I suppose, fundamentally is resources, or more often than not, lack of it. There's a constant issue regarding funding, but in terms of how that actually transpires on a day-to-day basis, we're talking about doctors who refer patients on to primary services that do not have enough resources within them to provide sufficient appointments for patients to be seen within a timely manner. And that can have massive knock-on effects for patients' well-being, let alone their actual condition. And that reverberates back to us here. So I, for example, only yesterday had to deal with a patient who was quite upset because she couldn't get her referral appointment in time to be seen and be dealt with in an adequate time frame to her. The time for people to wait now is getting longer and longer, and if you're suffering, for example, with podiatry issues where you can't actually physically walk, that can have big ramifications to your day-to-day life. And we're having to take that baton on behalf of our patients and trying to do what we can to assist them, but there are limitations. Then you've got people making decisions without actually knowing the situation well enough. So NHS England, for example, they closed a practice just down the road from us with no notice whatsoever, no contingency planning. And so consequently, they had patients who suddenly didn't have a doctor to see. That had big ramifications to us because it meant that they came to us to register with us, which is fine, but we had no contingency for that sudden influx of patients. There was no resilience funding for that. And so we had to, as a business, manage that as best we could. And this was over the Christmas period as well, so there was holidays involved. And so it created a lot of additional pressure for everyone throughout the business, both the administrators in terms of getting people registered, to the nursing team to get patients seen for their new patient health checks, to doctors who were dealing with repeat prescriptions that suddenly needed to be done here as opposed to their previous practice, where patients were feeling really anxious about where they're going to get their next prescription from. So that side of management from high up is very difficult, and so you're suddenly hit without any warning at all with a sudden influx of issues you have to deal with. And then of course there's the public themselves. Sometimes the public don't help themselves, which is, it sounds a bit of an odd thing to say, but it's very true. So there's a lot of people with type 2 diabetes, for example, who will not go for their regular checks, you know, to have their blood pressure checked, their cholesterol checked, or their blood sugars checked. They might do 1, 2, but not necessarily all 3 of those things on an annual basis. They might think, well, I'm okay, I don't need to go see my GP, and trying to get patients in to have that managed so we can assess them better has always proved a little bit difficult.
Is it about empowering the patient to make decisions about their health?
I think there's elements of that. There are certainly elements of that. You know, we all have to think about innovating how we work, no matter what line of business you're in, and healthcare is no different. We have to think about different ways of working within the constraints that we have. So, for example, we have big issues regarding confidentiality that we have to adhere to. But within those confines, there are certain things we can do, and empowering patients is certainly one of them. Getting people to work differently in terms of how they book appointments. So traditionally people would phone or come in to have their appointments booked. We've been pushing for a number of years to get patients to book online, not just to book their appointments online, but to see their medical records online, to see their results from any tests they've done online. So it minimises the impact to the practice, but also ensures that it gives the patient a lot more hands-ready information that they can just click on at any time, day or night, and it's all there for them.
Do you feel, therefore, that general practice has a key role to play in helping to modify patients' health behaviours?
Yes. So that's from general advice when patients come in to be seen for their checkups or whatever issues they may have. So GP imparting a certain amount of knowledge. Sometimes it's about changing their habits. Sometimes it might be even as simple as getting them to wear a smartwatch to help them, you know, monitor their heart rates a bit more and their general well-being. There are a variety of different things, but that has to also work hand in hand with what is coming from the very top. So there has to be an overall consensus, right, this is what we want to do for the patient to get them to manage their health better. And it has to be coming from everybody, so it's, you know, it's the same message directed from the top as well as from the GPs. One of the classic examples I use is is recycling. 30 years ago, as a nation, we never used to bother recycling anything, whereas the collective push has changed that. So people's perceptions about the benefits of recycling on our environment, etc. And healthcare is very similar to that. You know, if you're going to have big shifts in how patients deal with their own health, then that has to be something that is dealt with from the top as well as the bottom.
I'm sensing that in the way you've described your role, you're quite person-centred. So, do you have any comment to make on the way that NHS managers tend to be perceived, usually in the media? They tend to be maligned and perhaps criticised as disempowering clinicians. I wonder if you've got any thoughts about that.
Yeah, I mean, I think ultimately it comes down to, if I was sitting here doing nothing, then I think there'd be an argument for that. But the reality is very different. I come in, I do an 8-hour day, invariably more than that, and I'm non-stop throughout that whole time. I don't even eat until I go home because I do not have time to stop. We are here to support the clinical team. The big emphasis has always been about get the clinicians to just see patients and do the clinical side of the business, which I totally agree with. But they need support administratively. If they're going to do less administrative tasks, then we have to take on that burden. And that would be anything from just generally ensuring that they have the infrastructure in place to deal with things as they need to deal with them. Or it might be a bit more highbrow. So it might be more of the higher level stuff, so dealing with the finances, for example, that the GP partners just do not have the time to deal with. So there's a lot more to a management role than, oh, well, they're not doing much. Well, they were clearly there for a reason. People are rarely in management just to do nothing. And more often than not, they're there helping support staff and ensuring that they get the best out of their people.
So thinking about your job, what do you like about it the most? So what are the key opportunities?
I think on a personal level, I like the fact that I feel as though I am doing something positive for the community that I serve. So the ultimate thing is obviously being here, working in an environment that is here to help people. And that's probably the biggest nugget of gratification that I get out of it. But also, you know, aside from the patients, there's also the staff, and being here to support staff and ensuring we get the most out of them and their abilities. A bit of coaching where relevant, and just ensuring that they feel that coming to work is a good thing as opposed to, oh, I've got to go to work. One thing I've found over the years, that a lot of people go to work just for a little bit of normality. So whatever issues are going on in their private life, they can come into work and feel that, okay, we're going to deal with work, it's going to be the day-to-day stuff, I don't have to think about all the other issues I've got going on outside. And you almost want it to be a bit of a safe haven for people sometimes. And just generally from a personal level, I love the diversity of the role, feel as though I'm supporting my staff and my patients and my doctors as well. And just the sense of that you're doing something positive, as opposed to just having things ticking over and making some money for a few people. So I came from the private sector into the public sector because I was tired of making money for a few people, and I wanted to do something that was a bit more gratifying for me and more rewarding for people that I do the work for.
There's often a distinction drawn between the culture of a private sector organisation versus a public sector one. Reflecting back, do you feel that there's some joint learning to be done in terms of our different cultures? And perhaps in answering that, you could tell me what skills you brought from the private sector over to the public one.
Yes, I mean, there's been a lot of discussion over recent years about reforming the NHS, etc. And coming from the private sector, I wholeheartedly agree with that in principle. It's about how you go about it, I think, that's probably more key. I mean, some of the things that I still find astounding now is that, you know, we still have practices and services that use fax machines, which is just laughable. And I know there's a drive to eventually get them taken out of the service, but here we are in 2018. Some services are still using fax machines. So the employment of common sense and technology, for starters, is an obvious thing. But then you talk about other issues. You know, a lot of bodies in the NHS, they operate in silos. So you have various trusts, and various trusts have their own particular way of working, and there's everyone doing good and bad practice within one area, and then there's good and bad practice in another area. There doesn't seem to be as much joined up. If this was a national organisation run privately, it would never be run the way it's run. Now, there's key caveats to that as to the reasons why, but generally speaking, there's so much that it could improve on. But part of the problem is the political aspect of it. When the government comes to power, they want to put their imprint on the NHS, and they have a 5-year plan, because that's their term in office. And the reality is that a lot of the changes that need to happen into the NHS need to happen over much greater periods of time. And ideally, you don't really want the NHS to be governed by a particular party. I think ideally you want it to be accountable to a cross-party committee. But, you know, similar to the BBC, you do not want to have the NHS going one direction for 5 years, then going in another direction for 5 years. It's completely unstable, and it burns a lot of money. And I think ultimately we want to make sure that we have people who know about healthcare dealing with the governance of healthcare and delivery. And then they're accountable to the politicians about what they're doing and how well it's going. And if they're given that remit, then they could have, you know, a 10-year plan, a 15-year plan to do a much more consolidatory role in bringing everything together in a more cohesive way that works long term.
And a lot has to be said for integrated care when we're thinking about multimorbidity. So that is a global public health epidemic in terms of people having 2 or more chronic conditions. And increasingly we're learning how fragmented, siloed working doesn't work for those types of patients. Could you just tell me a bit about how your practice deals with patients with multimorbidity? Yeah, I mean, we obviously look at all the different chronic illnesses individually, but also try and see where patients have 2 or more issues and try and see those patients as a priority. So we run searches both on an individual level as people who have, for example, you know, who are obese, but then we'd have people who are obese and diabetic and have other issues as well, asthma potentially as well, and then see if we can see those patients that have 2 or 3 issues, you know, predominantly first, to make sure that they are given immediate health care. And so we tend to use reporting systems based on our own cohort of patients that we run on a monthly basis. And you would be facilitating that in your role?
Yes. As a practice manager, I'm the one in charge of doing the vast majority of reporting that we do. And when we have new doctors come in, so we are a training practice, we have trainee doctors who come in and do 4 months with us, FY2 doctors, and they, for example, getting to use EMIS Web, which is the clinical system that we use for the first time, and I have to show them how to use the EMIS Web reporting and how to define the criteria for the report and produce the report and export it where necessary as well. So, you know, basically from creation of the report going all the way through to sending out the letter to all the relevant patients, that whole process is done electronically, but obviously you need to know how to do that, and that's part of my role, to show people.
Great. I have 2 questions left. It seems to me like you get quite a lot of satisfaction in your job, but if you had to go with a plan B, what would the plan B be?
I think for me it would probably be consultation work, in so much as when I came here there were so many things that were still paper based, so many different ways of working to how we work now. I've been in this role for nearly 4 years, and in that time I've transformed a lot of the things that we did fundamentally. So whereas we had a lot of box files and paperwork everywhere, now we don't. I keep everything electronic, and it's much more easier to manage both here and remotely, because we log in remotely to our systems as well. If everything is kept electronic, it's all easily accessible. And CQC, they absolutely love that because it's kept secure, it's easily brought to the fore if we ever need it, and that works really well. So all the various aspects of that, I think I could go into any sort of practice and deal with on that regard. Part of my role is speaking to other practice managers within the borough, and through that I've also got involved in a learning group. So fellow practice managers, we all come together and we have a session on various aspects of our role. And so we can all learn from each other and do best practice. So training aspect is something that I could also potentially go into. And then of course then there's CQC or CCG work, which is also potentially an option to me. Having got my Prince 2 and a few other things as well, there's no reason why I couldn't go into that role as well. So I'm very happy here, but I think if I was going to wind things down in say 5-10 years time, then those are the sort of things I'd probably look into.
My last question was a take-home message to students hoping to become managers and leaders within public health. What would you want to impart on them?
I would say ultimately you just go for it. It's such a rewarding role for the heart and soul as much as anything else. And as long as you have the patient at the centre of what you do, then you can't go far wrong. I think when people start looking at stats rather than patients and not understanding the whole aspect of the patient's lives and what their little condition actually has in terms of their life and their ramifications of that, then as long as they keep that at the centre, they can't go far wrong in terms of what they deliver. If you go just dealing with statistics and nothing more, then you might hit targets, but you will not be serving patients.
Thank you, Riz.
Thank you.